dear colleagues, I'm very happy to greet you today. And today I will be giving an interesting seminar that is very practical in its nature. It is important for doctors who practice thread lift and are interested in new solutions. They are interested in more modern aesthetic techniques aimed at increasing their professional rating to make their work more effective, and your patients would get great results because of it. It is essential that your patients get 100% result, and they should be in harmony with the way they look like and with their inner state. The most important thing is that they are pleased with the results. Today we are here together with the girls looking at me. All of us are very beautiful, and what we really want is to have a wonderful face, which is absolutely young, and this is our main goal: to look fresh, to look beautiful, and to look as if we're a star. And today my workshop is a woman's perspective on thread lift. It is my contribution to the application of thread techniques that I will share with you. The seminar is all about the author's concepts. It is important that you develop spatial thinking so that you can choose ready-made concepts for different patients, then manipulate them freely, and also be able to draw up your own concepts based on the patient's needs. So my idea is that you choose what is the best for you, and then you can also develop your own concepts and your own techniques which will be the most suitable for your patients and which will meet their needs. So, all of our techniques work together. It is impossible to use thread lifting techniques alone to address facial ptosis and age-related changes. During my online and offline seminars and consultations, I always try to explain that, above all, the set of armoring threads allows us to work in the facial plane and improve tissue quality, create a firming effect, and simultaneously obtain additional aesthetic results in the form of increasing the volume of certain areas or reducing them. This is the idea which I try to translate to every patient of mine. We are trying to convince the patient to choose the technique which will be the best for her. So lifting threads allow us to get an instantaneous transformation. There are many different technical nuances in this technique, and we understand that in this case we will provide our patient with a very young and beautiful and new face. So before I go on to talk about my own techniques, I would like to discuss some important points. In a thread lift, details are of utmost importance. For example, there are some peculiarities in the way the skin gathers and moves on the different types of threads. So every millimeter is of great importance, and we should value every single moment of our work in order to avoid any difficulties further on. It is important to understand the technical nuances in order to apply them in your technique and to know what manual skills we need to have in order to achieve the aesthetic result of the lift. There are two categories of lifting threads in our range. The first category of threads is the bidirectional one. This thread is the most common and accounts for 95% of all lift threads on the market and is available from different manufacturers in different sizes and with different types of hooks. There are, for example, press cocks, and we also cover this topic in different seminars of ours, and we understand that there are students who are already aware of a lot of them. That's why we have to be concentrated on the main ones. So what is the peculiarity of lifting with a bidirectional thread? For example, let's take an 18G100 thread. These are the cannulae and the thread is in them. If I now draw the cannula, the thread with the hooks will be completely inside the cannula. This is correct, otherwise you cannot get the thread into the skin. It will clean before certain time. The K-ray cannula must therefore facilitate the insertion of the thread with hooks completely into the skin. The length of the cannula is 100 mm or 10 centimeters. There are two bobbed bidirectional segments which are oriented in a convergent manner. For example, they face each other. This model has 4 centimeters of bobs that look upwards. This is called the anchor. The bobs point upwards and kind of grab onto the skin so that it can be pulled upwards. The 5 centimeter is the fixation part. After pulling the skin up, the fixation bobs go into the tissue and hold the result. The smooth part is 5-7 centimeters. So one more time. In the end, all the thread is about 9 centimeters. So this is what we pay for. We, as the doctors, we pay for the material we work with, and our patients pay for this material and pay for the whole procedure. So, how is the lifting done with the thread model? The lower part of the thread, the anchor, has to engage with the skin with this layer where we insert it. Then we pull the thread and move the skin tissue upwards, providing a lift. In the diagram, I have depicted the skin tightening and the movement of the tissue on the different types of threads. The first thread is bidirectional. The bobs cling to the skin. We tighten the thread and gather the skin tissue on the fixing part of the thread where the bobs look down. It is important to understand that the gathered skin will go upwards with nothing holding it in place all along the fixing part of the thread. This skin may gather at the bottom as a blob. This is the way the thread technology works. So failure to understand This leads to the fact that we can see the additional volume where we gather the skin on the thread. So we see the tissues gather in one place and we see the volume being added. Accordingly, on the border of the directory, this volume can create a kind of step, a kind of some crease, or even a puff. So, a volume of varying intensity. So, therefore, it is undesirable to insert the thread superficially. And of course, we need to make this transition very smooth and mild. So you need to insert the thread deeper in order to make a softer transition. In practice, we will deal with such points in order to understand how to evenly distribute the tissue and make the transition absolutely unnoticeable. This is our magic wand, and at the same time we need a manual to use this wand. Otherwise, it won't work. In order to do this, you need to know the theoretical aspect of this thread model. Here we see the model in lift, and most importantly, I always draw a circle. This is our finger with which we fix the result. The upper part is 1.5 or 2 centimeters. This is the anchoring part of the thread, which is necessary for a more intensive insertion of the hooks into the tissue of this reference area. The 4 centimeter anchor hooks in the lower areas of the face where we have loose tissue, such as the cheek area. So why do we have these 4 anchor centimeter hooks? So in loose tissues, the fixation should be stiffer, so 4 centimeters of thread is sufficient. We stretch the lower part where the anchor is fixed, we flatten the upper part of the tissue, and the fixation of the result takes place in the upper segment of the fixation directory. So one more time, we have the result fixed in the upper segment, in the upper layer. And we see that this very part is the maximum loose skin, which is a bit stiffed here. As if we have a small puff of the skin. And we understand that the fixation here will be minimal. And we do understand that we have to hold it tight. So in the maximum loose skin tissue we have gathered on the thread, and the fixation will not be sufficient, you see? And in order to keep all tissues in the raised position, a small segment of the fixation part of the thread should be fixed in the dense tissues or in the reference areas. These are the scalp area as well as denser areas of skin other than the zygomatic region, for example, or the projection of the zygomatic ligament. At the basic level of the lifting workshop, we discussed that a lot depends on the condition of the reference point. By choosing soft zygomatic ligaments, we will lose the effectiveness of fixation of the entire lift because the lifting threads are on top, and it is desirable to have 1.5-2 centimeters of thread going into the dense tissue. We will attach the hooks so that they lock into place. This way, the entire lift will be placed on these 3 centimeters. Out of the fixation part, 3 centimeter remains. Anchor, lifter, reference point. This is how the tissues are distributed over 9 centimeters of thread. Also, these threads models have tips on the outside for easy fixation, so that the thread can be caught in the skin, fold, and the conductor can be removed. So the bidirectional thread may or may not have a tip. If there is no tip, once the needle is inserted, the thread must be pushed through the tissue so that the barbed part of the thread is caught, and then the carrier can be pulled out. But if you have this part of the thread, it is about 1 or 1.5 centimeter, it can be also moving, and we understand that it is 1.5 or 2 centimeters, and this will be absolutely sufficient in this case, and it will help us achieve the best result in this way. The second category of threads is different from the first. They are called fixation threads or fixes. I will put it like this here. So there are different terminologies of these fixation threads, but we are already adapted to this one. So what is the fundamental difference of this thread? All 9 centimeters of it have hooks. They are equal along their length, one way and the other way. In the thread model, I use 2 hooks, look one way and 2 the other way. The thread of the lifting on this thread model is that the gathering of the skin tissues is uniform along the entire length of the thread, without any peculiarities changing the contour of the tissues. These threads are available in 2 variants: with or without hooks. You can take a look at the comparison of the threads. You can take a look at the differences and about their similarities. Obviously, the result of the lifting will be different, so aesthetically it will be a different result. And we understand that we will bear it in mind while having some practical moments and experiencing something new. But a crucial point that I would love to discuss is how not to lose the hooks that we have inserted into the skin, how not to pull out some of the threads with the hooks, as well as how to increase the effectiveness of the lift and how to properly introduce the threads into the skin. Let me ask you one question. At basic seminars, I always ask the same question. What is the intensity of the lift we can achieve with these threads if we fully insert the carrier or cannula into the skin? So if we insert 10 centimeters of thread into the skin and then remove the carrier, how many centimeters can we pull up this thread while holding the smooth tip so that not to lose the first hooks? So how many centimeters? So the answer is by 1 centimeter. Yes, you are right. 1 centimeter of the smooth thread has gone into the skin, and the remaining 9 centimeters is with the hooks. If we don't apply additional manual techniques that increase the effectiveness of the lift, we may only get a 1 centimeter lift. What is the disadvantage of such a situation? So what is the disadvantage of such a model? A 1 centimeter lift is a very weak effect. We need 1.5, even 2 or 2.5 centimeters. To get 1 centimeter of lift, we can pull out the hooks, but the quality of the work will decrease. Sometimes we pull and pull and pull it one more time, but we understand that the quality of our work leaves much to be desired. When the hooks come out, one fixation directory that holds all the tissue fixation is also out. We will either lose the effect or the fixation or even both. It is very important not to cut off any hooks. In practice, this happens when the doctor does not fully understand the case. We understand that it may happen, but our goal is not to lose the effect and not to lose our result. That's why we have to apply all our efforts not to do that and to try to solve this issue and to understand how to react in such a case. Sometimes when the doctor is unaware of the mere importance of this case, the doctor can become a bit taken aback. But in this case, we should instruct him or her how to do her best while working with such kind of a model. So in this slide, we can see that 3-4 centimeters of hooks are cut off. Sometimes 5 centimeters of hooks are cut off. Thus, the anchor hooks will not be effective after cutting them off. Failure to understand the design feature of this thread pattern leads to a poor work result. So, if you cut off part of the fixation thread, the effectiveness of the lift is not lost, but in the bidirectional threads, as the thread has the same hooks along its entire length. So you can cut the thread for small areas of skin, 6-5 centimeters, where 9 centimeters is not needed. For the bidirectional threads, on the contrary, this is a problem. During the first years of my practice, I also faced the loss of hooks. Then I realized that it affects the result. I began to look for new techniques that increase the effectiveness of the lift and preservation of the thread in the skin. My technique is called the author centimeter. With an additional attachment of the skin to the needle or carrier, we capture the thread and pull it further about 1 or 2 centimeters. So what is the essence of this technique? We hold on to the connector or holder, which contains 1.52 centimeters of smooth, sterile thread that we can use. Once one of my students told me that it was my author centimeter, and then I agreed. Maybe this is the best way to describe it. Thanks to this part of the thread, we can pull the hooks deep into the skin, obtaining this author centimeter. The construction of the thread already includes 1 centimeter, and there is also a smooth part of the thread in the connector, which means we have an additional 2 centimeters for maximum lift. So, one more time, I would love to draw your attention to the fact that this part of the thread is sterile, and we have to pull this part of the threads out of the skin, and in this case we can add this 1/4 centimeter, and it will be a really good construction in such a case. So all in all, we understand that the construction of the thread already includes 1 centimeter, and there is also a smooth part of the thread in the connector, which means we have an additional 2 centimeters for maximum lift. Can you imagine that? 2 centimeters. This is a method that I use in all my techniques. If I see that the hooks start to come out in the process, I see that there is a minus for me. For example, I didn't get a 5, so I didn't get a maximum mark for my work. It will be like 4.5 points for me. So, but I'm not satisfied with the result in this case. So I try to pull the thread more carefully. So this information is really up to date, and I would love to draw your attention here as well. There are a lot of problems here, and a lot of doctors do make mistakes. But what I would love to mention here is that, for example, on social media, I often find the work of doctors who use Korean rigid cogs on the zygomatic ligament, where the working part is 9 centimeters. But there will also be hooks coming out on the zygomatic area, as its size is smaller than the working part of the thread. So you can also measure it. And if you insert the entire cannula into the active mimic area, which is unacceptable with my technique, you will count no more than 8 centimeters of tissue. So we are girls, and our faces are really small in comparison with the men's faces, for example. And we understand that the needle does not always enter completely, and we need not only to insert it completely, but also to gather the skin on it using the author centimeter technique. Accordingly, it is very important. Please put it down. You should use 18G to 100 or 19G to 100 needles, like 10 centimeters needles, which represent 80% of the both, like our market, Korean market, and the total thread market. So if we divide all the market, and if we imagine that all the market is 100%, we see that about 90 or 95% is these 10 centimeters threads. So such long threads should be used for long vectors. I have a long vector drawn of 10 centimeters plus 1/4 centimeter, which will end up being 11 centimeters or even 12 centimeters. When you do the marking, you have to see if the vector is suitable for such long threads. If the vector is shorter, you need other threads, otherwise the hooks will come out. We have roughly drawn a projection on the threads where you will see the injection point and these 9 centimeters. Next, pull the threads upwards. The upper part of the fixing directory is in the tied reference point. So we understand that the upper part of the fixing directory cannot help but be in this tight and very dense skin in the tied reference point. You can put your fingertips on this area and try to make a massage there, and then put it on the reference point into the scalp area. And you see the difference. You see the difference, and you see that the sensitivity is different here. So the cheekbone area is lower, making it impossible to make good use of our instrument. The patient is pictured with 3 cogs on one side and 2 on the other side. Minimum number of threads. The injection point was on the zygomatic region. The fixation directory was cut, so the result disappeared after a week. And we understand that the result was not okay. And the patient was really stressed because she saw that the result disappeared. So there is one more patient which was absolutely dissatisfied with the result. And we understand that for example, this very patient had a thread break because the fixation part of the thread was cut off and the reference zone did not hold all the gathered tissue. And she was very worried because of this thread lifting. Now let us take a look at this patient. It is also a very interesting case to discuss. So you see the video, and I used this video and I applied testing the comprehension of my methodology principles. So you see how this doctor is acting here. We understand that this doctor is not a very good professional, of course. So what is wrong here? It is wrong, first and foremost, because of the vector which was misused and which was not chosen in the right way. So, wrong vector, it is short for the thread model. Also, let us take a look at it one more time. The reference zone is wrong because we are going into the active mimic area and Korean threads are rigidly fixed, so they cannot be inserted there. Now we look again and we remember the smooth tip that we have for easy fixation at the end of the thread. We can see that the doctor is inserting a rather long tip. On the outside of the face, there is a long tip. When we insert the thread, it experiences friction and pulls on the skin, so it is important to hold the smooth tip so that it always stays outside. In this example, the doctor is holding the needle, not the connector, not holding the outer tip, and as a result, the tip comes out, which means that the lifting thread is inverted. The anchor ended up on the outside. The fixing part, about 4 centimeters, was left on the inside. It starts to pull the skin, and it starts to pull on the skin further on. You see it? If it cuts off a couple of centimeters, the result of the lift will be minimal. So let us see what happened here. So this is the manual about how not to do the thread lifting. So it is like the anti-advertisement of this doctor, of course, and of the method of inserting lifting, like inserting lifting techniques. So we understand that this doctor does not understand the most definite and the basic principles of the thread lifting, and the doctor can't implement her knowledge in this case. So this, you see that this vector is real. Is a real mistake, and this vector is shorter, and the result will be absolutely useless, and there won't be any result. So the thread will be inverted. It will look in the absolutely different direction, and she won't be able to draw the thread, and there won't be a result. There won't be even 4 centimeters inserted. That's why we see that it is a failure. It is a very bad mistake in this case, and we understand that we should not work like that. Never in our practice. So we see how to do it. Like, for example, USB 1.0, like bidirectional, then USB 1.0, like fixing thread, like unidirectional, then equal threads with different features, like USB 3 bidirectional threads, and USB 2 for working through denser tissues and problematic vectors. Also, we have double needle threads, they account for 50% of the threads on the market. I can give you some certain characteristic of these kind of threads, and we see that there are 2 needle threads. So these threads are being entered as a loop, in the form of a loop. They have a smooth part, like 2 centimeters. So if you unfold this thread, it is the same as the bidirectional thread. All barbs look upwards. You have to make 2 punctures and 2 hollows to insert this thread. So we can't insert this sterile this sterile thread, like I have just shown it to you, like on this very scheme. So it is the type of the surgical thread that we use when the specialist needs to hold the needle, pull it through the tissue, and a lift takes place. It is a traumatic technique. If we cut off part of the thread, it is not a big deal, but it is used to insert the thread from top to bottom. So if we have shorter vectors, we can use this model. We understand that we can use it for upward lifting and not the downward lifting, for the ascending lifting, not the descending lifting. So we can't invert it, we can't put it topsy-turvy. In this case, we won't have any result at all. In this case, we will have the lifting like this, and we can raise it along the entire length of it. But in this case, we will have a result like this. So there won't be any fixation along the entire length, and the skin will be gathered. So if we flip it over, the bulbs look down. We can lift the skin upwards, but there is no lift in the upside down state, unfortunately. It is important to move the tissues upwards, but we have to bear all these peculiarities in mind, because these particular features of the threads should be always taken into account. We should not forget about them. So, for example, bidirectional threads, like divergent barbs, are used to stretch the skin. The Koreans like to stretch the skin on the nose to lengthen it. So they try to make their profile longer. So in our case, with the Russian faces, we don't use it. It's not popular. Such threads are not common in Russia. So unidirectional bobbed threads are armoring threads with additional traumatic options. These are thinner filaments than conventional cords, USP4 or USP3. We can use them for the body, for example. We can use some different threads for armoring the body. For example, the intensive USP 5.0 thread, like 9 centimeters monofilament. It is used for body armoring. This kind of thin thread is enough for large volumes like abdomen or buttocks. We can take USP 3.0 or USP 4.0 like monofilament. You can place the threads differently so that the hooks do not shift due to gravity. So here we speak about the intensive armoring. The thick threads like USP1 or USP2 or USP3 do not have them at all. So here you see a similar thread. It is depicted here as a mono thread, but it's really big. Now let us take a look at the new one. So my question for you is, what kind of a thread is it? So it is USP 3, like bi-directional thread. So you see this design and you see the bulbs, like different kinds of them, like different variants of them. And you see that if we insert this skin into the layer of, if we insert this cannula, like U cannula, as you see it here, into the skin layer, we see that it will be hooked all the entire length of it. So here we see like XXL shock lifting, and we see that there will be some gathering there. And all these bulbs will be fixing the skin very tightly. So when we speak about the vectors, we'll see how to apply all these threads, because in practice it will be really different. Like USP2, for example, 2 needles are used to lift the tissue up and distribute it evenly. The effect is similar to that of fixing threads.